We've come to the end of the first segment of the second session. We'll be moving to the second segment of the second session. This segment is on selected and interesting case studies that focus on some of the long-term complications that may impact long-term outcome. Each presenter will have 12 minutes. At the end, we'll have 10 minutes question and answer session. Having said this, I'll be inviting our first speaker, Roberto Rauda, who is our Chief Transplant PA. Roberto has more than 17 years of experience. I would say that he's the backbone of our post-transplant care in the floor. Please join me in welcoming Dr. Roberto Rauda. By the way, Roberto will be talking to us on diabetes after transplant. Thank you.
Thank you, Dr. Naji, for those kind words. When I started working here, I had more hair. And I was more better body shape than what you see right now. So I'm going to start with a case presentation. But before that, I want to thank Dr. Rochon and Dr. Markel for allowing me to be one of the presenters. I lead a team of the mid-level providers. We have 2 amazing nurse practitioners and 4 PAs. And we hold the fort in the transplant unit. So my case presentation is about this 30-year-old male African-American. He was admitted in May of 2021 for a kidney transplant. His past medical history included end-stage renal disease, secondary to hypertension. He had been on dialysis for 14 years. On admission, his glucose was 102. The patient underwent a deceased donor renal transplant in May of 2021. So in the OR, we gave the patient thymoglobulin and Solumedrol as per our center protocol. The kidney transplant made urine immediately in the OR, and by post-op day 1, he was making over 2 liters a day. On admission, his creatinine was 13. So the hospital course wasn't remarkable. The blood pressure was controlled with his home medications. The inpatient hyperglycemia was treated with Novolog sliding scale, and his finger stick peaked in the 160s. By the time he was discharged, the blood glucose was 95, and the kidney function was 1.6. So usually we remove the Foley catheters to prevent the risk of infection. The day of the discharge, the patient was discharged on our usual protocol medications, and we sent him home on prednisone 20. And prednisone is usually tapered down every week. Our pharmacist writes down the exact date on when the patient has to reduce the prednisone by 5. So by 1 month, if the patient needs to be on prednisone, there would be 5 milligrams. Usually we do our multidisciplinary rounds, and when we deem the patient stable for discharge, we send the patient home with a close follow-up. Our social work arranges for visiting nurse to continue medication teaching at home and to encourage medication adherence. The clinic follow-ups, the first few clinics follow-ups, the patient was doing well, blood glucose was normal, kidney function continued to do well, and the hemoglobin A1C was 5. But by August, the hemoglobin A1C increased to 8, and the random blood sugar was 190. The urine was negative for protein, so the patient wasn't showing any signs of allograft dysfunction. So at this point, patient met criteria for post-transplant diabetes mellitus. So the outpatient team started him on repaglinide with meals, In October, the patient came to clinic and he reported to the team that his blood sugars had been in the 300s, 400s a few days prior. So he was complaining of weakness, polyuria, excessive thirst, and poor appetite. So the patient experienced some weight loss. So he was sent to the emergency room for evaluation. In the emergency room, the patient had uncontrolled high blood pressure. The blood pressure was in the 180s over 114. Blood glucose was in the 500s. Kidney function was slightly elevated. The ProGraph level was 16. And he was very acidotic, so the patient was admitted to the medical ICU. The medical ICU did an amazing job. He was treated with aggressive fluid hydration and insulin drip. And endocrine was consulted, and within 24 hours, the patient was back on the floor. He was started on Lantus and Aspart. And a few days later, he was discharged on metformin, in addition to Glargine and Aspart. After that admission, the patient did well. By a few months later, he was off insulin. He was following in the endocrine clinic. Blood glucose was normal. He was on metformin and Prandin. And the hemoglobin A1C was a target level at 6.5 to 7.1. And to be honest with you, I have never seen this patient again. He's been doing well because I work in the inpatient setting. The last clinic visit was in February, and he's doing well. Kidney function is doing well. Blood glucose is normal. And I believe he's only on Prandin. So hemoglobin A1C is at target level right now. So I'm going to present to you post-transplant diabetes mellitus. And this condition was first described in 1964. And by 1970s, it was a well recognized problem after transplantation. So in order to have diabetes after transplant, essentially the patient has to be a non-diabetic before transplant, right? So the terminology has been changed throughout the years. In the beginning, it was called steroid diabetes. At some point, it was called transplant-associated hyperglycemia. Then it was called new onset diabetes after transplant. So this is, as a short term, we call it NODAT. But this term was abandoned because it excluded patients that were not diagnosed with diabetes prior to the transplant. But sometimes we still use it on the floor, NODAT. It sounds very interesting, the term NODAT. So when medical students come or visiting fellows from other hospitals, we tell them that the patient has NODAT. So they are taken back. They think it's something weird, because it's a transplant patient, so we have a weird diagnosis. But we tell them it's just diabetes after transplant. So this condition can occur in about 50% of high-risk patients, and is usually diagnosed 3 months after the transplant. It can result in impaired kidney dysfunction, and it can cause major cardiovascular complications, and it's associated with decreased patient survival. So the risk factors, we group them into modifiable and non-modifiable. The pre-transplant risk factors such as age, obesity, male gender, right, genetic background, increases the risk for post-transplant diabetes by up to 50%. And then in addition to these modifiable risks and non-modifiable risk factors, we introduce a new condition, right? We introduce immunosuppression. So we give them steroids, which can induce insulin resistance, and tacrolimus, which can also cause glucose intolerance. So the criteria to diagnose diabetes, the patient has to have no diabetes before the transplant. Patient needs to be receiving stable immunosuppression regimen, and he must not have an acute infection. And we use the ADA guidelines to diagnose diabetes, the same as the general public. We use the fasting glucose, the random glucose of 200 with symptoms. And the gold standard is oral glucose tolerance test, but this is usually not performed in the centers. But what we use is the hemoglobin A1C of more than 6.5. But this has to be used at least 3 months after the transplant, because in the beginning, we have a lot of confounding factors, like the patients may be anemic, may have acute anemia from blood loss, patient may have blood transfusion, so the glycated hemoglobin is not reliable in the beginning. The diagnosis of diabetes after transplant could be very challenging. The challenges lie in distinguishing between transient hyperglycemia, persistent hyperglycemia, and post-transplant diabetes mellitus. So in the beginning, transient hyperglycemia is it could be related to surgical stress. Body releases all the stress hormones that could have antagonistic insulin activity. And we also give the high dose steroids. And then we have the persistent hyperglycemia post-transplant. And this most commonly occurs in the setting of pre-existing diabetes, but it could also be representing a rapid onset post-transplant diabetes. And this condition could develop months to years post-transplantation because the immunosuppression causes dysregulation of insulin secretion and action that could happen when we give steroids and Prograf. So the importance of diagnosing diabetes as early as possible is because this condition could cause allograft dysfunction. It could cause diabetic kidney disease, and this can result as a deleterious synergistic effect when the patients develop infections, they become more immunosuppressed. So this could lead to major cardiovascular problems and a higher mortality rate due to cardiovascular events. So prevention should start before the transplant. We should encourage our patients to lose weight, to develop lifestyle modifications, to control, help them control the blood pressure, lipid levels. And we also have an independent factor that could cause diabetes after transplant, which is hypoglycemia and hypomagnesemia, And this could be a side effect of Prograf. So while the patient is taking Prograf, we always fighting the magnesium levels and introducing a magnesium oxide for the patient. So it's always a battle with hypomagnesemia. And the most important thing is to tailor the immunosuppression. To give the right dosages is very hard. Just like Jane mentioned, this is where the art of transplant lies into giving the right dosages to the patient. The treatment of post-transplant diabetes could be very challenging in the beginning. Immediately after transplant, the glucose levels could be very high. So we usually use insulin analogs. We may use Lantus or a Novolog together. Remember that in the beginning, also the conditions are changing rapidly. Patients feel bloated. The nutrition could be impaired because of the introduction of the mycophenolates. So nutrition is impaired. So this could lead to, when we give the insulin, they could become hypoglycemic. So it's a challenge in the beginning. Some of the oral hypoglycemics that we use have advantages and disadvantages. Metformin is one of the first-line agents as per ADA guidelines. This has less risk of hypoglycemia. And then we have the glinides like nateglinide and repaglinide. These medications increase insulin secretion and reduces postprandial hyperglycemia, but they could cause increased uric acid and dizziness. And then we have the dipeptidyl peptidase 4 inhibitors. These medications could increase and prolong incretin hormone activity. And we also have the sulfonylureas like glipizide, which increases insulin secretion. And then we have the sodium glucose transporting 2 inhibitors like Jardiance. We seldom use these medications. The patients are placed on these medications when they go to the endocrine follow-ups. But we use a combination of these medications usually. By the time we discharge the patients, we try not to send patients on insulin. We may use a combination of Januvia, or we could give Januvia with one of the glinides, like nateglinide. It's easier for the patients to use these medications, easier than insulin. So some of the takeaway points that I have is that the management of diabetes should begin pre-transplantation. Patient counseling is very important. We should encourage weight loss, diet modifications. We should coordinate care with the entire team. And adherence to medication is very important. We should keep glucose monitoring at goal. And hemoglobin A1C should be between 6.5 and 7.5. Yearly eye exams are very important. And every time the patient comes to clinic, they should have feed examinations. And modification of immunosuppression is very important. So to balance the immunosuppression, it's one of the keys in maintaining normal glucose and helping the patient to prevent complications in the kidney transplantation. And that's all I have for you.
Thank you, Roberto. Rauda, you emphasized important practical issues, considerations, and also you talked about theoretical considerations in management of patients with diabetes post-transplant. That was an outstanding presentation. Thank you so much. 50% of our patients with kidney transplant are going to, unfortunately, die while their graft is still functioning. We call this death censored graft loss, while 50% are going to lose their kidney while they are still alive. For patients with death censored graft loss, cardiovascular disease is the leading cause. And diabetes is a very important risk factor for cardiovascular disease. That's why Roberto had to talk to us about diabetes.